I'm just going to do a land acknowledgement. So although this webinar is offered virtually and we're welcoming participants from many parts of Canada and around the world, it's still important to recognize that our school has a physical location. And so we'd like to acknowledge the sacred land on which the Adler Graduate Professional School operates. It's been the site of human activity of Indigenous peoples for over 15,000 years. The land on which our school building sits is the territory of the Huron-Wendat and Petun First Nation, the Seneca, and most recently the Mississaugas of the Credit River. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, which was an agreement between the Iroquois Confederacy and the Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. So today, the meeting place of Toronto is still home to many Indigenous people from across Turtle Island, and we're so grateful to have the opportunity to work in the community and on this territory. Thanks everyone for joining me in that. I'm going to start with some very quick technical notes. If your internet connection is cutting out, there's also an option to call into this session over the phone. So those details are included in the registration email. And the presenters are going to be taking questions throughout this webinar. So if you have any questions as we go through, there's two ways you can ask. You can raise your hand on Zoom. You'll see that as an option on the panel underneath. So if you raise your hand, we can give you permission to unmute yourself and turn your video on. So that's up to you if you'd like to use that. If you would rather just type your question in, you can use the Q&A function. That's also on your panel. So you can go in and you can type your question in and we'll answer it as we go through. So you can choose which option you like, and I will let you know that the session is being recorded. So if you would rather not have your name read out or have your voice or your image, then please type your question anonymously into the Q&A. And as I mentioned before, we also have an awesome chat function. So if you'd like to communicate with other attendees, introduce yourself, share resources, feel free to share your resources and comments there. Remember to select all panelists and attendees when you're chatting so that everybody can see your comment. And that's my kind of technical notes. And welcome to today's Many Hearts webinar. These webinars are co-sponsored by Adler Graduate Professional School and the Alliance of Psychotherapy Training Institutions. These are an opportunity for mental health professionals to share the heart of their practice with other practitioners in the wider community. We're really excited to have you all today and really looking forward to this webinar. I'm going to pass it along to Annette Smith. She's been with Adler for many, many years in our registrar's department in lots of capacities. And she's going to introduce our speakers for today.
Great, thank you, Camille. I've had the pleasure of working with Beatrice and Wayne over many years in different capacities and contexts, and it's always been rewarding and informative, a great experience. So I think you're in for a really great talk today. So I'm just going to go through the bios for both Wayne and Beatrice because both of them have such a wealth of experience that without notes, I would miss at least half of the important parts. So we'll start with Beatrice. We'll go alphabetically. So we'll start with Beatrice. Beatrice Traub-Werner has spent over 30 years in the field of social work as a clinician, administrator, and educator. She was the Director of Admissions at the Faculty of Social Work, University of Toronto. A visionary and entrepreneur, Beatrice founded TAPE Educational Services in affiliation with the Continuing Education Division at the University of St. Michael's College in the University of Toronto. Through TAPE, she developed continuing education programs and certificates for healthcare and human services workers, teaching both in-house and at agencies or organizations. In 2009, Beatrice partnered with the Mennonite New Life Center and began the Bridge Training Program for internationally educated mental health professionals, which continues to operate now with a new leadership team under the name of BREM. In 2012, Beatrice joined the Adler team as Dean of Continuing Education, where she creates, oversees, and teaches Con Ed courses and programs. Over the years, she served on and chaired a number of boards of directors, and from 2007 to 2017, she was an elected social work member of the Council of the Ontario College of Social Workers and Social Services Workers, and spent 3 years as its president. In 2021, she was elected for another 3-year term. Beatrice is completing her second 3-year term as an elected member of the Board of Directors of the Association of Social Work Boards based in Culpeper, Virginia. VA is Virginia, right? I think so. I should know that. There are many people working in human services education who've been supported by Beatrice in one way or another, and I'm one of them. In 2006, I was going to apply to the Faculty of Social Work at the University of Toronto, and because Beatrice had been involved with that school, I asked if she would look at my application. She looked at it and very tactfully said, your skills would be far better put to use in the education sphere, so please come and work with me. And so I did, and it's been a great career so far. So Okay, so we'll move on. I always tell Adler students that when they have a chance to take a course with Wayne Skinner, they absolutely should jump at the opportunity, and I'll tell you that now. So I'm really happy to introduce Wayne today. Wayne Skinner has taught at Adler for over a decade in courses on addiction, concurrent disorders, motivational interviewing, and cognitive behavioral therapy. He's held appointments as the assistant professor in the Department of Psychiatry and adjunct senior lecturer in the Factor Inwintosh Faculty of Social Work at the University of Toronto. From its founding in 1998 until retiring in 2016, Wayne played a leadership role at the Center for Addiction and Mental Health, CAMH, heading its concurrent disorders program, and more recently leading the Problem Gambling Institute of Ontario, and serving as Deputy Clinical Director for Addictions in the Ambulatory Care and Structured Treatment Programs. Prior to CAMH, he worked at the Addiction Research Foundation as a clinician, clinical supervisor, program director, consultant, research investigator, and educator. He is a member of the Motivational Interviewing Network of Trainers, MINT, and an active MI trainer. He's given presentations and workshops on a wide range of topics related to addiction, mental health, and concurrent disorders, nationally and internationally. Wayne edited Treating Concurrent Disorders, A Guide for Counselors in 2005. In 2007, with Caroline O'Grady, he authored A Family Guide to Concurrent Disorders. With Marilyn Harry, he co-authored Substance Abuse in Canada in 2010. He authored with Carolyn Cooper, Motivational Interviewing for Concurrent Disorders in 2013. And in 2014, CAMH published Fundamentals of Addiction, a practical guide for counselors, edited by Marilyn Harry and Wayne. The first time I worked with Wayne and Beatrice in an educational setting was over a decade ago. I don't know if you remember this, but we recorded an audio recorded a conversation between Wayne and a medical doctor, I think Luis Fonassari, about addiction and treatment from different perspectives. It was amazing talk. I learned a lot, but to be frank, I am very glad that we have moved on from really clunky audio equipment and into the wonder that is Zoom and a webinar. So I look forward today to learning from both Wayne and Beatrice. And so very pleased to welcome Beatrice Traub-Werner and Wayne Skinner discussing why motivational interviewing matters.
Thanks so much, Annette, for this wonderful introduction, and welcome everybody. Yes,
thank you indeed. It's a pleasure to be here, and it's a pleasure to be doing it with you, Beatrice. In a certain way, well, when the invitation to do a talk came up, I had a strong feeling that this would be the topic that I would like to talk on, but also the idea that you would be participating and collaborating with me, and it was another motivator. In a lot of ways, I think this topic is a thread, if you will, that describes the journeys of both of our careers in a number of ways. Me as somebody who's working in clinical settings, you as an educator and an organizer, almost at a time, an impresario of learning in continuing education, and so we've had a chance along the way to actually collaborate in this area, and you've been a great champion of helping professionals actually learn more of this stuff. So anyway, so it's great to be doing this today with you.
Always fun to work with you, Wayne, and I'm always the beneficiary of all your knowledge. I've learned so much on the way, and so today we're ready to share what we both have learned on our journeys.
So we're starting with a conversational style, and we'd like to keep that, actually. We've got stuff we want to get through, but also we're hoping the way we get through it can be helpful. So to you, the folks who are listening. So if you have comments or questions, there'll be points where we'll stop too and kind of gather those up. And we're hoping there's time for discussion at the end as well. So, but having said that, maybe we should just, let me see how good I am at sharing screen here and getting us started. Okay. Okay, so this is our topic, and it's in some ways it's curious in a way, right? That we need to talk about this, but I actually strongly believe we do need to talk about it. Why does motivational interviewing matter? It's my job, I guess, to make a case for this, and it's your job to actually reflect on that, and maybe you've got some questions, and so I invite you to kind of engage in this in a kind of critically reflective way, and I'd be curious to see where you end up at the end of this, but think about where you are at the start too, actually. So we've kind of organized it around a bunch of questions, really, and we've what do we know about this, the whole area of interpersonal skills? Are there skills that could be called therapeutic skills? And then we'll go more specifically into motivational interviewing. What is it? And then what is something that MI calls MI spirit? Are there some principles that sort of organize how we work in MI? What are MI skills? What are the processes that, what does MI look like if you're doing it, if you will? And in some ways, MI isn't necessarily that kind of a thing, but you could recognize it as well, and we'll try to illustrate this as we go along as well. So the thing for me, actually, in terms of the invitation to talk about this today is to lead to these questions at the end. What are the implications if we're serious about this? What are the implications for clinical practice and for professional training, right? Because I think that actually this perspective allows a bit of a critique that we've been heading down the road in the wrong way, perhaps, when we've and I'm a guilty party here too. So it's not about trying to target somebody else, but the way that we lean into professional education and practice in some ways has created a bit of a blind spot that I actually think that's where the secret is, if you will, in terms of how we help people. So that's kind of the overview, and again, we framed it around a set of questions that we're going to explore as we go along. Beatrice, did you want to comment?
Only in as much as Wayne and David Brown and I, who teach together the addictions and mental health course that we call Biopsychosocial Plus in concurrent disorders. We've had this conversation in our sort of off teaching times. In what ways might it be beneficial to help, especially newer practitioners, to feel their way and grow in clinical practice? It is harder these days, we think, because we're hearing that in many agencies, the growth of the practitioner is not essentially what is focused on. The work is so intense and there's so much to do, you just keep doing. So I worry a bit about burnout, having been there and done that. So yeah, let's dive right into this. Our journeys into clinical practice. Do you want to get started?
For sure. So in a way, I'm old enough actually that in some ways my career includes some of these milestone dates. Let me kind of put this way. I guess I was a university student in the late 60s, early 70s. When I had completed my third year of undergraduate study at the U of T, I really didn't know what to do with my fourth year. So I decided I'm not going to come back until I figure it out. I took a leave and I got a job at Queen Street Mental Health Center working as a psychiatric attendant. And it was the time when the hospital was opening up. There were locked wards, they were moving people into the community. It was a very invigorating time and a very optimistic time, actually. And I really, what I began to realize also is that often in those in that environment, there's a range of people with a whole bunch of different credentials and stuff. But actually, the people who were actually the best helpers weren't necessarily the people with the most kind of high fancy degrees and stuff. And so that got me kind of interested in what is helping. And I began to read sort of the literature on empathy, and particularly Carl Rogers' kind of stuff about reflective listening. And so with that kind of experience, I ended up in the School of Social Work. They let me in, Annette, rather than, and Beatrice guided you to a better destination. But I was quite interested in this issue, and as I was reading, then I began to read literature that suggested that people enter this field probably with high levels of empathy to start with, but that one of the costs of professional education is that people, when you measure their empathy leaving and going into practice, they actually had less of it. So, are there ways actually that we train people that these qualities are diminished actually rather than enhanced? So just a question, but again, some literature back from then around it. So my work led me to the Addiction Research Foundation, where I had a student placement and I was later employed, and kind of a set of learning opportunities where all of my sessions in my second year were in front of a one-way mirror, and they were taped and watched. And I can tell you that made me a nervous wreck, just even approaching the environment to start with. But I soon began to realize, what an incredible learning opportunity I had. And so as my career continued along, I became very interested actually in kind of counseling skills, and ended up doing some training. And along the way, some literature starts to appear that raises questions about this. And so I've got several names here that kind of capture some of the decades. But for those of us in addiction, Bill Miller in 1983, and then in 92 with Rolnick, started asking some very interesting questions about how do we interact with people. And that's a whole conversation. I won't go there today, but again, what it did was kindle this interest in interpersonal processes and counseling skills. But at the same time, like anybody else and everybody else, it seems, I can be very seduced by therapeutic methods. So as different methods of doing therapy came along, I always had my hand up for wanting to do the training and to learn about anything from, let me think, CBT, obviously, to dialectical behavior therapy, to ACT, to attachment theory, to whatever, which and so I'm definitely drawn that way. And in some ways, when I notice professional education, that seems to be what the focus is on these new treatment methods and the like. But this literature starts to ask some questions about maybe it's not just what we do, but the ways we do what we do that matters in helping. So, is the how as important as the what? And for me, that's been a kind of an absorbing thing, and as we go along. So as far back as the 60s, Truax and Berenson were doing actually work on empathy, and they put out this question which they saw as the central one. What are the essential characteristics of the therapist or counselor that lead to constructive behavioral change in the client? Like, is there something about the therapist as much as the method that actually helps change happen? And so that kind of starts the steam, the ball rolling to where we are today. Another quote, actually, and this is referring to work that Miller was doing in the 80s. And here they say that they were able to strongly predict clients' outcomes. Actually, in the most effective way predicting it was how well their behavioral therapists listened to them. So, wow, like what is, that seems like such a simple thing, feeling listened to or being able to observe that, and using that as a metric for therapy outcome. What they found actually when they did this work was, this was actually a study where they looked at 10 therapists, and they found that one therapist who had the most empathic rate had 100% success rate. Now, I mean, nobody, that's amazing. But the least empathic therapist, the one who wasn't able to listen as effectively at all as that, their success rate was 25%. On average, the counselor success rate was 61%. Now, in that study, actually, what they did was they gave people a self-help manual. And what they found was that with the self-help manual, that 60% of people were doing well. So anyway, this is another kind of aspect of the way therapy has emerged, right? And now, certainly in the online era, tools and products that that are there for people to work on their issues are really exploding exponentially. But this is interesting. So what it suggests is that the therapist empathy effects average out at around the same as the manual. Although when you look within the therapist group, you can see some strong differences. And so again, like what's going on here, right? And then this idea that even 2 years later, when they did follow-up, they found that the empathy of the counselors still predicted good outcomes for people. So in 1999, a book was published called The Heart and Soul of Change, and it was published by the American Psychological Association, a very empirically oriented organization. They're not into soft therapy at all. You've got to have an evidence base to it. One of the articles in that book or chapters was by two writers, Assay and Lambert, and it was about something I call Lambert's pie. That's my folksy term for it. But Lambert was doing these meta-analyses of psychotherapies across cultures, actually. And what he found was when he did these meta-analyses that you could actually identify 4 key sets of factors that predicted client outcome. And so if we were in a class, we could play a game on that. We're on a line, but here's what he found. He found that actually the biggest factor in predicting therapy outcome was what he called extra therapeutic, and they were the factors that belonged to the client. So how how early in the game and how much social support a person had, that was in favor of the client doing well in therapy. How severe and complicated and lack of social support is going to be harder to help somebody. So definitely these extra therapeutic factors, if you will, as he called them, are important in therapy. So the therapy involves 60% of the pie, basically. And so it turns out that technique, all that stuff I was craving to learn about, the CBT, the DBT, the ACT, all of that accounts for about 15% of therapy outcome. This is a startling finding actually in his study, that actually expectancy, AKA the placebo effect, also known as hope, the ability to engender hope in somebody, predicts therapy outcome as much as technique. So engendering hopefulness in people, and that kind of goes the other way too, right? The more demoralized we are, maybe that has predictive value. Bill Miller, kind of the MI guru, says that optimism and pessimism are sort of self-fulfilling prophecies. And so our attitudes might be quite important. But what's the last thing left here? And it's the therapeutic relationship. So actually, if there's anything we have control over, it's that. And so again, it's not to forsake technique and all of that. That's an important ingredient, but also this ability to engender hopefulness in working with the client. And then what is the therapeutic relationship? What does that consist of? Sort of that then gets us on the way, I think, to why I think MI matters. So, but it also raises these questions. Maybe we shouldn't be as interested in creating new schools of therapy, but maybe we should be interested in developing better therapists, right? And what would training and supervision look like, actually, if the emphasis was put on the qualities of the therapist and the counselor that improve outcomes, regardless of method? So anyway, those are, for me, very, very important questions. So all of this comes together quite neatly in a book that was published actually earlier this year by the same Bill Miller of motivational interviewing fame and his colleague Teresa Moyers. And so they have actually put together a text that identifies what they see as the clinical skills that therapists, when they possess, make them effective and improve client outcomes. So I just want to kind of slide on into that quickly, and but let me also pause here for a moment to see. First of all, do you have a comment, Beatrice? And is there anything that anyone in our audience wants to comment on at this point?
Someone was asking what the 40% represented, and I just wrote in the chat about the extra therapeutic factors, which have to do with the person engaging with you, what they bring to the session, what they bring to the work.
Yes.
What kind of supports they have, how ready they are, and so forth. Go ahead.
And so when we just to amplify that a little bit, when we think about it in working with addictions and people with co-occurring disorders, we use a biopsychosocial approach to, so what are the is this person in good physical health? Do they have physical health liabilities? What's their mental health status? Or are there issues there? What are the social factors that are either creating drag, if you will, on the person, or creating opportunity for change? And we've added two other factors. We talk about culture and we talk about spirituality, because in kind of recovery-oriented thinking, they become very important elements to identify as well. So those factors that belong to the client and their world are factors that we can work with in counseling, and we try to identify and kind of draw on and enhance those as we do our work.
I also wanted to speak a bit to the comment, what if training and supervision put the emphasis on the qualities of counselors and therapists themselves that improve client outcomes regardless of the method of treatment? Part of the reason why we do continuing education as a requirement for professional development is because the feeling is that the techniques, as important as they are, will lead the counselor or the psychotherapist to find avenues to grow and to stretch. So in a way, learning about techniques is also about exploring the self and reflecting on what it is that you're doing when you're doing what you're doing. And we hope that this talk today will actually do that, particularly. That is one of the aims. We want to be sure that people realize that it's beyond, skills are important, but it's beyond skills. The relationship really, truly matters, and how to develop that.
And I really appreciate the point you're making also, that the effective helper really is a critically self-reflective person who actually engages in, reflection on their work. They prepare, they seek feedback, and the title of becoming effective therapists, I see as an endless journey rather than like a place that you arrive at and you're done, right? Every time we sit down with a client, we're beginning anew, and we have to earn it in that here and now time that we spend with people. Definitely, as we get experience and stuff, we build that, and we can hopefully be better in what we do. But that longing, if you will, to be better is really, I think, at the heart of continuing education, really, and wanting to be a learner.
And okay, I think so one of the issues that I think concerns us also is the fact that there is such an emphasis these days in sort of the speed, go, 8 sessions, you're done, out, next. I wonder how replenishing, or how effectively you can replenish when you're giving, without the opportunity to reflect and to learn and to grow. And so the worry about burnout is is there. I'm hearing and I listen to what many of my younger colleagues are saying, and they're finding this time particularly stressful, and it is. So yeah, let's look at therapeutic skills. These are the things that will keep everybody going and going better.
That's a great point too, Beatrice. Usually we're in a milieu where we're physically present with other people doing variations on the same work. And usually we get to see our clients, we get to shake hands with them, have direct eye contact, and we're living in a virtual milieu now. And it's amazing how well people have adapted to it on the one hand, but I think your point is an important one, that maybe there are burdens that come with this, right? And things that as we hurry up to keep doing the work, we don't notice perhaps, but yeah, I think self-care and as helpers, it becomes really important thing to be reflecting about, and also to finding practices that work for each of us. And for us as teams too, right? How can we continue to have that experience of milieu, of being together, in virtual life? So these are the skills that Miller and Moyers identify as, they call them the therapeutic skills. And the first 4 particularly are ones that kind of come from Rogers and Kharkov and Truax. And so they've long been with us, if you will. And then these other ones that have been added as more information and knowledge about what makes a therapist effective, has kind of been identified. So I'm just going to quickly walk us through the first 4, and then we'll move on to MI. So accurate empathy then is this ability to, through active listening, through reflective listening, that we're able to mirror the client's experience. And they have a sense that we're getting it, right? And sometimes this involves taking gentle guesses at what may be unsaid. And when these things when accurate empathy is happening, actually, the evidence is that clients are more open to self-exploration. They're less defensive, if you will. And actually treatment improves as well. So when this quality is present in the therapeutic experience. Acceptance, and this is kind of interesting, because sometimes we work with people who maybe there's stuff going on that, can we be accepting, if you will? But, whatever the behavior, this idea that we believe in the inherent worth of the person, and that actually when people experience being accepted as they are, that itself can start a curative process, right? And as I mentioned earlier, our beliefs about human nature can be self-fulfilling prophecies. So if we expect the worst, we're going to start noticing it. If we expect good things, actually, we start to see it. So an accepting and respectful style reduces defensive-ness. And in a way, this might be as much about what we don't do. So in acceptance, we don't disapprove of people, we don't criticize, we don't disagree, we don't label them, we don't feel we got to warn them, we don't shame them. So it's actually taking those things out of what we normally might be doing when we're interacting with people. And these things can occur very subtly. They don't have to be very explicit. We now know about sort of microaggressions, and so there's a micro level to and the client will experience this. People who are feeling vulnerable, who are hurt, have incredible antennae, right? They've learned that they have to be self-protective. So, the counseling experience is actually trying to create a more open space where the person learns to trust you and also to trust themselves. And that's how we move ahead together. Positive regard is this, again, there's these notions of sort of unconditional respect, a benevolent disposition to the person. Appreciating that this person has strengths and that they have growth potential. And when this happens, again, defensiveness lowers, we start building the alliance, and outcomes are enhanced. And then the fourth one I want to look at, just quickly, just to kind of tell you what's under the hood. Genuineness is our ability to be warm and open and honest, actually. So a lack of phoniness, and this gets to be really interesting, because it gets into the area of self-disclosure, or like how do we use ourselves with clients, and then congruence really is how much is my self-perception and my experience, how much does it line up? And so the client's got eyes for this, but also part of this is also our ability to be self-accepting ourselves. So, we travel with stuff on board as well. The client isn't kind of a strange alien force who doesn't have, being the only one with human problems. And our ability to know about ourselves, our vulnerabilities, our triggers and stuff becomes very important in being able to do it. So the self-acceptance we're offering to the client requires that we know how to extend it to ourselves as well. So the other thing that Miller and Moyers make is that these aren't personality traits. Like, they might exist variously in people, but they're skills actually. And that's the important thing in terms of professional education, that these can be improved over time. And so that's why, rather than sort of fatalistically looking at who's got what, the learning journey really is about what do I have, and how can I cultivate them to a higher degree, and what am I weaker in, and what do I want to be, how can I be stronger in those? So this is just a stop point to see if there are any comments or questions.
There was a question in the chat from Heather Hennick, who is asking about, let me just find it quickly, what about constant client resistance to change?
I love it. Actually. I think the construct of that, when early in my career, when I started to get interested in these interpersonal counseling processes, and particularly in MI, I would get invitations to go to conferences and stuff to talk about working with the resistant client. This was one of the ways this was often put. The other was the hard to help client, so the constantly resisting client, that's a very interesting constellation, right? Because that suggests that in the dynamic between me and the client, whenever I say yes, the client will say but, or no. Whenever I push, the client will push back. And so, what is that dance, right, that's going on there? And so MI is very interested in how to dissolve that, right? It's not a very unique problem. It actually probably is very, very common. So let's hold on to it really and explore it as we go. And I don't know if what I've said now is enough. I don't want the questioner to be frustrated. But that is, as I can just say, that's a very fascinating and all too common constellation, right? Where we have some clear idea about where the change ought to go. The client is saying, no, I'm not going to do it. And so it's a perfect situation for a stalemate, in working together. So MI actually has some, in a way, kind of radical views on this that we'll get out on the table here pretty quickly. Beatrice, did you have a comment or?
Deanna has asked whether this has to do with transference and countertransference. And I suppose to a certain extent it does. But it also much depends on the position that you take. If you are the expert and you know what is best for your client, and so you're pushing in that direction, chances are high or higher that you're going to get pushback. Whereas if you are walking by the side of your client as his or her guide, perhaps, let them decide. They are the best knowers of what is best for them. It's not up to me to decide what is good for you. You tell me, and I'll try to find a way to help you get there. But if I decide this is where you need to go, it's not going to work as well. That's really at the center of MI as well.
And that's definitely supervisory wisdom, right? When that's happening, and you could look in the area of transference, like what's going on in me that's activate. Am I contributing to this by something in me kind of becoming active? That's the countertransferential part. The transferential part is the client's. Are we're just not getting along, and that's worth a look. So, but let me just say one thing before we move ahead here. Then MI actually has stopped using the word resistance, and in a way, an MI adage would be, where there is resistance, let there be ambivalence, and in a way, resistance could be looked at as what happens when we deal with the client's ambivalence in particular ways. So let me try to kind of make the case as we go ahead here for that. Actually, we're in a spot here where we can demonstrate maybe some of what our questioner was asking about. So shall we go to this right now, Beatrice, or what do you think?
Yeah, it's a good idea.
Okay.
This is a demonstration of one way of doing things.
So it's a physician talking to a patient who is a smoker and a parent.
Hey, just real quick, listen, if you're a coach,
sorry about that,
trainer, and you need more clients and you're struggling to grow and scale your business.
So I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so. Yeah. That's really a big problem. Yeah, it's pretty stressful for both of us. He gets really upset. Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I mean, I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard. So I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard, people have told me before, I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time.
There's no reason why you shouldn't be able to quit. This is really important.
I understand that. I know it is. I mean, everybody has problems, right? It's just really, really hard.
Well, what can be more important to you than the health of your child?
I don't know.
I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things and I'll find, I guess I'll try to find something and I'll talk to my doctor about it.
Okay, well, I think you really need to think about this seriously. Like I said, it's really putting yourself and your child in danger. Okay, whatever. Okay. Okay.
Okay. So, what do you think?
Now, it would be nice if we could get all the audience to go, so what did you think? Yikes, right, thank you. Yeah, another yikes. Yeah.
So let me just, I'm doing a little technical thing here, lining up the next one. Okay, so I mean, what was wrong here in a way? Was there anything wrong in what the doctor was saying to the patient? You know, was she incorrect in anything she was saying?
All the information was totally correct. It's just everything was said in the wrong tone, in the wrong way.
Yeah, sorry.
People are saying no empathy for her struggle, shaming, not encouraging, bullying the mom into it. Right. All of that is absolutely true too.
So all of those things actually then that we identified as sort of the other side of therapeutic skills, they were in play here. Now, was this doctor concerned about this patient? Was this doctor concerned about the child? Absolutely, right? And did she have the right information? She had a lot of information, right? And is she going to be able to write, what kind of a note can she write? She can write a note about how I said all the right things and the client said all the wrong things. In spite of all of what I said, the client kind of did yes, but on best medical advice. I've made tons of suggestions. I did all of this stuff. And so clearly what happens on the client, right? If you look at it that way.
Perfect note, wrong way, wrong results. Perfect note, wrong results.
Okay, so let's switch over to another version of this, and we'll give her another chance. I apologize. There's a bit of an ad that's going to come on here, I think. Let me hang on. Go to share screen.
Book, Nomad Capitalist. It's available on Amazon, and I wrote it myself to help.
Watch what happens this time when the provider cues into what the parent is saying, empathizes with her situation.
For antibiotics for Aiden. I did want to talk to you though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job. And so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah. Exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you're able to stop.
Yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people. And like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
you're doing the best you can do.
Yes.
Okay. But it sounds to me too, like part of you really does want to quit.
Yeah, I know that I need to. And I, keep every new year, I say, okay, this year I'm going to quit smoking. But then something happens and it just doesn't.
It's on your to-do list. It's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mom is doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you. And sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure. It feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
So, what do people think?
Some people didn't like her. But
The doctor?
yeah. Well,
Yeah.
A doctor is a doctor, and that's kind of the road. But at least there was a lot more going, and all of you identified that. Yes, thank you.
I like that people acknowledge that they had a feeling, full reaction to the doctor, right? And that's actually very, very interesting, because I wonder a lot when people come into our environments and they're meeting us for the first time, what kind of experiences are already on board? Like how many have been really positive, experiences where these qualities of accurate empathy, acceptance, positive regard, genuineness, just hospitality and warmth has been, experienced. Probably a lot of people are coming in, I expect, kind of pissed off actually, or expecting something not so good to happen, when they're coming in. So it's really important to think about what is the effective charge, even before you've started talking with somebody, right? And that we have our own charge too, right? And we can be, the tone, maybe it was her voice, was it a little too high pitched, or, these things, and so that ability actually to discern that is, I think is part of a professional self-reflective practice. So I really like that that was noted. So I'm just going to go back to the slides here. Are there any other questions and comments that were coming in?
Yeah, good comments. Validation, mirroring, empathy, active listening, eye contact, reflective questioning, all of that was there. Yes, it was a completely different set of circumstances.
So
there were some questions in the Q&A. Sorry if you have.
Please, no, go ahead, Camille.
There was one from before. I'm not sure if you'd covered this when you answered the last question, but one question Debbie Bauer was asking, I thought we should avoid advice. I know there's another question there, but if there's any response you have to that.
Yeah, so in MI, there actually advice is important. And sort of the way that MI thinks about it is the clients, they're the expert in themselves. We're sort of the expert in like the broader set of things, right? So what has helped people in the past? What do I know about, you know, this or that? And so, and they can be very helpful to people, right? So MI is about setting the stage for effectively giving advice and not just proffering it, you know, in the way in the first session that the doctor was just throwing stuff out of there, you know, this sort of gift bag of things that, so in the second one, she made some suggestions. The important thing was that she noted that the client had objections to them and didn't start to arm wrestle her around it. She just said, oh, okay, maybe we need to talk some more about this. Maybe this needs to be something that's really good for you. I'm just giving you the general things that I recommend. Maybe we need to talk a bit more about it. So advice is actually, and knowing how to give advice is something that MI actually has some good guidance on.
Right, and you want to sort of ask the client, you want some more? Is this the right thing for you? It's part of the way you connect.
Yeah.
The expert is on the other side. I don't know what's good for you. I know what's generally good, and I can offer you what I know. Is it good for you? You decide.
One good tip is to ask the client what they've tried before, you know, what's worked, what have they heard, those kinds of things. And you could ask the client if they, you know, if they would like some input from you too. So the MI approach to advice is to ask permission, if you will, or if the client's asking you, you've got permission, then you offer the advice. But the important thing in MI is the next thing you do, which is to ask the client, what does that sound like to you? So it's because that's what's really important in helping. It's not that I said a right thing. It's like, how's this falling on the ears of the client and how are they digesting it? You know, and that's what you get to work with when the client answers your question, when you ask back on it. So tell me what that means for you, or, you know, so that's the kind of move in MI. We're always moving towards the client, and we're trying to get them to tell us what, you know, what's the meaning of what our exchange is. And so, you know, I ask this question often, and I think about it a lot, right? How important is it to be right, or how important is it to be effective? And we live in a world where we get huge admonitions from our managers about our note taking and about, like, you know, liability and all of that. In both of these cases, the doctors could write a note that, you know, if somebody said, well, what did you do with this person? You know, something wrong happened after that session, and you know, maybe you had a hand in it. You know, both of them could say, well, look, I was great. And it was the client in the first case who gave me resistance. And in the second case, the doctor didn't see it as, it was ambivalence, right? She actually said, you know, well, I think from what you're saying, part of you would actually like not to be a smoker. You know, you're saying it's really hard to do and you don't know how to do it, but that doesn't mean you don't wish you were not a non-smoker. So tell me about that, right? So really, you know, therapeutically, the challenge is where we're seeing resistance, can we actually start to see it as ambivalence? And how can we work that ambivalence so we have a different kind of conversation with the client, where we're always telling the client the right thing to do when they're saying, but yes, but I can't do it, or yes, but I'm hopeless, or, you know, et cetera, et cetera. So being effective in a lot of ways is a different mindset than technically being right. And so that's, I think that's an important part of skillfulness in therapy, this idea of, okay, what does effective mean? Okay, any other comments or questions coming in?
So there was another question, and I know that Beatrice had mentioned before, sometimes you only have 8 sessions because of the client's insurance. And an anonymous attendee had a question. They said if the client gets 8 to 10 sessions after a motor vehicle accident, they're most likely to complain about everything. In my experience, a lot of them are not ready for any change. They need to accept the loss first. And what's the best way to work with these type of clients?
So yeah, I think, so most of the work we do in the community is in a brief treatment context, right? It's usually 8 to 12 sessions or something like that. And we have enough clinical savvy to know that our clients have a lot of stuff on board. So the challenge, but also the opportunity in that 8 sessions is to find what can we focus on. And so in the case that they were giving, I would see the client being able to accept their illness and that they need to plan on a long course of recovery, say, as that would be a perfect focus for the treatment, right? So it's not as if so that's where the work might need to go, is that, wow, you know, you had a terrible thing happen to you, and now you have to think of your life in really, you know, such different upsetting terms than you maybe ever thought you would have to. And so, you know, is that what you want to talk about? Like, or, you know, maybe we can do that. You know, that could be the work that we do, so that actually, you know, at the end of this, that you're in a better space around that. And maybe part of what we can talk about is what that forward journey needs to look like for you, or what are some of the options you face, choices that you can make, so that you're in control of your life as it goes ahead as much as possible. So that you know, so again, framing it that way might be, you know, a way of identifying what's the workable opportunity here, right? But certainly when clients come in with a ton of things, and they often do, that's a bit overwhelming. But I do think the opportunity is to get that organized and to figure out, okay, what are the first steps that we can help with here, and to make the client a believer in their own future and in working for it, whatever that takes, right?
When it comes to MVAs, there's also all kinds of other agendas in and around the issues that have to do with insurance and compensation and fault and all of that stuff. So I think centering on this has been a really difficult experience, and what can we do first? And first is accepting that life has now changed significantly, and perhaps for a long time. That's not what the insurance company wants to hear. Therein is the problem.
We often think of behavior change as something that you do that's manifest on the outside, but there's a whole bunch of internal behaviors, the way that we talk to ourselves, the way that we treat ourselves, that actually, you know, is fair stuff, really, and important stuff to work on when we do counseling with people. And so in this case, I mean, again, in terms of the particular scenario, there's a whole lot more you'd want to know, but you know, is that really the behavioral space that we need to work in? It's more that interior space rather than, you know, the person and their relationship with other people or whatever. So what is MI? And I'm gonna go quick here. And so the demonstration actually laid out some things, and your responses identified, you nailed a lot of stuff here. And so one of the good messages, by the way, of MI is not something that everybody doesn't have, and now I'm here to tell you that you got it. MI actually works with stuff that's already in us. And what it really does is it helps us parse out what are the useful things in my skill repertoire, and what are the things that might not be so useful when I'm doing therapy. And so maybe some of those, the more I can leave some of those things outside of the therapy space, the better it might be for my client. And so MI, it's got a bunch of definitions, and the one that is most heartfelt for me, and I truly believe it, is that it's a way of being with people. but it's not the only way of being with people. But it really emphasizes that when we're with our clients, that we need to be with them, right? And so, so what's that all about? But the inspiring thing, in terms of us as practitioners, is that it's a set of skills that can be taught and learned, right? So, and what are those skills? So the skills are typically described as skills that are simple but difficult to learn because they take discipline to apply them. But also, MI is about more than skills, and MI is really first and foremost really about spirit. And so it's a particular way of talking with people that's collaborative and it's evocative, right? So what we're trying to do actually is draw out more and more from the client rather than feeling we've got to infuse this person with all the motivation, all the knowledge, all the readiness. How can we find that in the person? How can we cultivate it? And how can we use that really as the energy going forward? Because the truth is actually outside of our session, unless the client's got a really good memory and stuff, whatever happens then is on them, right? And so ways that we can get that cultivated and activated really is kind of that's what we can bring in therapy to people. So again, this starts in '83 when Miller was actually looking at some of the traditional approaches to working with addictions. And he actually wondered, rather than us telling people they need to change, maybe the client should be making the arguments for change. And what are their own concerns and motivations? Like, why would they want to change? And can we listen with empathy as they say that to us? And rather than kind of feeling we got to resist people, because there's attitudes to people who have addiction issues, and that one of the attitudes is that they're liars and they're in denial all the time. And our job is to wrestle with them until they admit that that's true, that they're going to change their ways. And how can we nurture hope and optimism? And originally it was a modest thing. Maybe we can use this just to get people more ready for treatment. And over the years, actually, MI has proven itself as a standalone treatment. But the good thing about MI too is that it can be added to just about anything anybody's been doing. And so MI enhanced CBT, there's a literature on that, and a whole bunch of other approaches that that are out there. These are just, I'm going to quickly scan these things. So it's not really a theory, or it's really very atheoretical in a way. As I mentioned, it places an emphasis on the fact that counseling is skillful, and that there are ways of learning how to maintain and enhance those skills, and that a lot of it involves learning, especially from our clients. And particularly when we can get immediate and ongoing feedback on the work that we're doing. So MI is very, very oriented to that. So I mentioned that I would get invitations to give talks about the resistant client or the hard to help client. And basically I would try to dissolve that idea and say that, like, what we really need to do is replace that idea of resistance with the notion of ambivalence, and that most of us have mixed feelings. In fact, a lot of my life is, the verb isn't in the dictionary yet, but I'm pushing for it. I spend a lot of time ambivalating, looking at this side and that side, what should I do, right? And so that's how it is with a lot of people, right? So people who have behaviors that have been important to them, and symptoms are not unimportant to people, by the way. Symptoms really are the way that people manage what they've got to deal with. And so they might want to be rid of them because they're causing all kinds of other effects. But in the absence of alternatives, I would advise a client to hang on to their symptoms, actually, so how do we work with that? But we believe in change, right? So that's it's not that, in a way, everybody's doing the best they can, but that best they can is the best they know how. And in therapy, we're trying to actually expand that space of know-how so the client actually develops some other skills. So MI spirit is very much those congruent with what we were looking at in terms of the therapeutic skills. We articulated in terms of these 4 concepts of partnership, acceptance, compassion, and evocation. And I'll just quickly walk us through those. So if we act as really a partner, or a companion, and we see our job as collaborating with the patient, really, and we want to draw on their experience and expertise in the work that we do, we're actually doing this for a person and with a person. We're not doing it on a person. And how can we activate that person's motivation and also the resources they have, internal and external, for change? Acceptance, the ability to communicate that we consider the client worthwhile, that we have empathy for their situation, that we affirm, we see them, there are good things about them, and that we want to support their autonomy, that can move forward in their lives, kind of being more, feeling that they're more the author of what's happening to them. So these notions, again, you could see they articulate, again, some of the therapist skills. So worth of the client, empathy, autonomy, support. That is, you need to make choices, client, and you have a right to make those choices. Compassion really is this ability to act benevolently in ways that promote the person's welfare and gives priority to the patient's need. And so it's a deliberate real commitment, right, to the welfare and the best interest of the other person. Evocation is kind of interesting because a lot of our work we think of as psychoeducation. And we see the client as an empty vessel that we've got so much good stuff we could fill them up with if only they would listen. Well, the problem is they don't listen in that kind of way, right? Some of them come in actually and do say, teach me. And where you don't have ambivalence, you can just get on with it. But actually clients, the belief in MI is that clients have their own wisdom, they have their own experience, and we should be trying to draw on that. And we should be trying to understand the client's perspective. And so what we're trying to do is evoke what's present in the person rather than actually seeing them as empty spaces that we've got stuff to fill up. So it's eliciting the patient's or the client's own perspectives. And again, the language here, we could say patient, client, we could just say person too, which is actually the language I prefer more today. So for those of you who are peeved by the word patient, I apologize. And I would actually suggest person is a better word. So some do's and don'ts in terms of MI spirit are kind of are here. And so it's constructed really in terms of these four interacting ingredients, could be remembered through the mnemonic PACE, P-A-C-E. And at the heart of it is empathy, this ability to be concerned about the person and try to understand what it's like to be in their shoes. This is a picture I use sometimes to describe that. Often our counseling sessions were sort of face-to-face to people, but in MI, we're actually trying to come alongside somebody. And this is a picture actually of a farm in northern British Columbia. And when I visited, it was this cloudy day, and I asked my hosts, two women, I said, like, what's those chairs about? and they said, well, some days, those clouds go away, and actually behind them, there's a really beautiful mountain there. And so we sit down and we just look at it. And in MI, I sort of see this as the same process, that really the client's inviting me, if you will, as much as I'm inviting them. And I sit down beside them and they're going to share with me things that I can't see, right? But that they have in view, that are part of their experience. And as I have that exchange with them, they're going to feel that I might be interested in them, that I care about them, that there's a connection, that they're worth the time I'm spending doing that with them. So there are sort of four principles in MI practice. I just want to quickly get us through this as well. I'm saying quickly a lot. I'm noticing the time. We've got 15 minutes left. So there, to express empathy, to develop discrepancy, roll with resistance, and support self-efficacy. So we've talked about empathy. Now the discrepancy is interesting because the discrepancy isn't between me and what I want you to do and you and what you want to do. It's actually between inside you. On the one hand, you want to quit smoking. On the other hand, you don't think you can do it right now because you're so burdened with being a parent and all of that. So let's talk about that, right? And so let's look at discrepancies between where you were and where you are now, and how you can close that gap, or where you want to be going forward. Discrepancies between your values and your current behaviors. These can be very motivational kinds of things to So we're trying to develop that with people. Where we get resistance, we don't actually say, aha, I've got you, and move in for the kill. We actually step back, we respect it, and we go to where we can keep the conversation going. And the direction of all of this is actually trying to support the client's self-efficacy, that we believe the client can be a more effective author of their own lives, by the choices they make, by the skills that they acquire. And so this ability to change, right, is the sort of the core belief, if you will, that we're carrying with us when we do this. The MI skills, so for most of the time I did training, I focused on 4 skills, and we remembered them through the mnemonic OARS, O-A-R-S, and we would have a lot of nautical images and stuff to do this. But so MI is as simple as mainly doing this when you work with people, and that is asking open questions, or just asking questions even. A closed question can be turned into an open question by, if it's a yes or no, and the client says yes or no, by saying, tell me more, or I'd like to hear more. So we can, I don't want to fuss about whether it's, closed question is a good or bad question. Questions are good. Affirmations are things that we notice about the person that are worth noting and crediting with the person, so like you've really, you're back here and you've had frustrations before, but you still want to work on a solution. Reflections are, noting things that the client has said and reflecting them back. Sometimes we might be making a guess about the feelings they have. Those are kind of considered more complex reflections. And then summaries are what we offer as ways of pulling together bits of things. Maybe we want to move on and focus on another area, so we're using it to transition. We could use it at the end of the session, but it gives us the chance to choose also what we want to do. And more recently, MI has given more attention to this thing that our questioner was asking about earlier, and how do we give information, advice, and feedback to people? And so MI uses this ask, offer, ask kind of model, and works on tiny bits of information rather than giving somebody a sermon on change and the like. So there's a method there that MI is very committed to, if you will. And again, any of these things that we talked about here, we could do whole hours on them and explicate them in great detail, but we are kind of moving along here. So I'm just going to go, what does the process look like in MI? So MI really, you could think of it how you'd work in a session, or you could think of it as you would work over a series of sessions too. To start with, we want to engage this client. And using the OR skills, we do that. Then as the client starts expressing their concerns and stuff, we would try to find, what can we focus on? Like, what are the issues? And then what will our focus be? And then the next thing would be to evoke from the clients why this is important for them right now. And then the final thing is to make a plan. And then what are we going to do? How are we going to do it? Now, the neat thing about MI, I consider it neat, is that actually for MI, a good session can involve just the first 3 of these. And MI's observation in a lot of counseling is that it goes prematurely to planning. And it's like, I figured out what you need to do, so let's just start doing it, right? I've got the answer. If you would just listen to me, I can give you a solution starting right now. But we haven't engaged, we haven't focused, and we haven't evoked. Okay, and so the client's somewhere back there, and we might be ready, but they're kind of like saying, what do you, like, really? They're doing all the yes, but stuff. And so, really, MI gives you permission to just do the first 3 and then see where you get to in terms of the plan, right? But if you do that well, it will lead to the plan, and it will be a plan that's collaborative, that it needs to be something that the client is agreeing to and is deciding on with you, rather than something you're prescribing to them. So that's sort of the MI process. So the implications for practice, I want to just touch on that before we run out of time. So there's lots of ways that we can become better clinicians. And one is through the idea of deliberate practice. There's micro skills training, getting feedback. Clients in the sessions are hugely important in MI for getting feedback on how we're doing. Also, our own self-review. We could get feedback and coaching from experts, supervisors. focusing on the idea of working the working alliance and seeing using measures or scores actually that are used in that area that get the client to rate the alliance as well as the therapist, belonging to collaborative communities of practice, and also outcome monitoring. How is this client doing? And I thought I'd had a great session with them, but gee, they had a relapse. Sometimes it's I thought I had a bad session, but they're doing really well. But being able to know how clients are doing, that's really important as well. So these are ways that we can do this. Deliberate practice is really when we look for focused and systematic efforts to improve skills, and then we're getting feedback from either experts or from clients, and then we will have increased expertise. So these are models, if you will. And again, humbly, MI keeps saying one of the reasons it's possible to keep on learning and improving our skills is that we have the opportunity of immediate feedback from an expert who's in the room. It's called our client or the person or the patient. So anyway, so these are kind of ways that we can learn interpersonal skills. And MI is not trying to dismiss the methodological skills that go into CBT, the technical skills, if you will, the other ones at all. It's actually, its view is that when that comes together with interpersonal skills, that you're going to get optimal therapy. But there are many ways that this practice can be advanced. Certainly demonstration from having your practice observed. My early experience of finding myself scared to death in a setting where I was going to have to interview people in front of other people, and then come to depend on it. When somebody wasn't listening to my session, I felt I was getting a raw deal because I needed the feedback. It's very difficult these days, I think, to be in environments where that's possible, right? But there are other ways I think that we can continue to advance our professional training. So anyway, so this idea that in a way it comes down to kind of therapeutic presence, and Millers and Myers noticed that's a bit of a paradox, and it requires both kind of our practices, if you will, the skills, but also an attitude or a spirit. And so MI tries to bring that spirit and skill together, and it makes it learnable for somebody like me. My gosh, there's 5 skills I need to focus on, right? I can remember what spirit is. And so it's really a great toolkit. And it's more than that. It's actually a set of values and an orientation that I can use. The big good news here is that all of this work that is oriented to these empathy-based approaches are evidence-based practices. As that Lambert's pie showed earlier, that the more that we can bring this into our work, the more our clients are going to thrive in the care that we give them. So there we are.
Whoa, that was quite the marathon.
Yeah, and I apologize. Maybe I like longer times where there's more chat, but here we are. Anyway, thanks for people being patient and listening if you're still there.
It's always amazing. I must have heard this. I always learn something new. Every single time. Thank you, Wayne. We had a couple of interesting questions. One of our audience members was interested in finding out how you factor compassion into all of this. Well, I would say that it is the substratum of the whole thing. You can't do this work without compassion and empathy.
I agree. And so I think that's a challenging question in a really important way. And so because sometimes it is hard work, and sometimes it's with people who've got behaviors, if you will, that are just so unacceptable, so terrible, that where's the room for compassion, in all of that. So that's a big challenge, right? And that might make it hard to do this work this way, right? So that's a fair comment. And it, one of the other qualities we talked about was genuineness. So this is not about faking it. right? So we have to come to grips with stuff in ourselves too when we do this work, and that's fair. I don't have a simple answer for that.
We had a couple of questions in the Q&A. I know we've got a few more minutes left. Debbie Bauer was asking, or commenting and then asking, great ideas, but have limited time with client and expectation of stakeholders. Any ideas of how to get around this?
Okay, that's a really great question, because MI actually has really kind of exploded as an intervention that's used in a whole variety of settings, including emergency rooms, where a doctor has like 3 minutes after doing his assessment, he's walking the person out of the examining room or something like that. And so the way that you talk to people is important in those moments. And there's some evidence that even just little episodes that are where the therapeutic skills, the MI skills are used, actually can have a strong impact on people. So one of the tips there that in emergency rooms that they found was it's actually much better to, rather than telling the patient what they need to do next, like in the first interview that we saw, a better question when you're, even after a brief conversation with somebody, is asking them, so what are you going to do now? And getting them to tell you what they're going to do now. And the other thing I would say is that there's some good evidence that when you're trying to refer somebody from place A to place B, that if you do that using a motivational interview, that actually more people arrive at the second place. So there's that. I mean, there's actually empirical evidence to support that. So MI, don't think that it needs to be a really systematic thing. Yes, if you have that opportunity, then certainly use that. But there's lots of opportunities that are micro moments, actually, where some of these skills actually can be, so it's not just motivational interview. Maybe there's a motivational moment that you're having with somebody, and how you react to that person, and the message you carry to that person about their possibilities and the way you see them can be really, really pretty important.
That sounds great. There's another question from Erica Benici. Can you give an example of how to roll with the resistance?
Okay, let's see. Well, maybe we can even try to find it in the interview that we listened to. The doctor a couple of times said to the patient, well, there's medication you can take, and she said, I don't like drugs. It sounded kind of wimpy, didn't it? But I'm kind of with her. I don't like drugs either, so I don't have a problem with that. But anyway, so the doctor didn't say, well, wait a minute, like they could help you, She didn't yes, but. So in a way, you're gonna notice that this person, and you're gonna go on. And she went to something else actually, and so she made a second offer, and that was about like, well, maybe self-help or getting together with people, and she said, oh, I don't think I have the time for that. And so she rolled then to say, well, maybe I don't have anything in my toolkit for you, that I can offer you right now. I would love to, but maybe we need to talk some more about this. Would you be open to talking some more about finding what's going to be your solution? And so that so that's, for me, she rolled with it in a very kind of interesting way, because she rolled through kind of biopsychosocial in a way too, right? And looking at kind of areas where the person could get help. But noticing one of the things that is a good trigger for me actually when I'm working with clients is, or just in ordinary conversation too, is I go yes, but a lot. Like, and so I've really taken that as a flag for me. I mean, so usually yes, but is permission to butt in actually and start saying what I think is right? But actually that's, really it's a flag to roll with resistance. And so MI actually talks about this, something it calls the writing reflex as a way of actually dealing with this. And I've got it queued up here actually as a parting tip I was going to offer. Maybe I can go to it right now and show folks. Let me go back to share screen and see if I can get it. So, okay. So here's a tip on as you head out the door here. So there's this human tendency to correct what we see as wrong, right? And so in MI, we call it the writing reflex. And it's this tendency actually, and it gets us often into advice giving, premature problem solving. We know what the answer is. And it actually short circuits the process of engaging the client. And kind of one of the axioms in MI is that pushing, predicts and produces pushback. So when we push, that an ambivalent person is going to push back on things. So the rule that MI uses is called RULE, and MI has all of these little mnemonics that you can remember. Like, what are the skills? Well, they're ORs and informing. They're what spirit? It's PACE. PACE. So how do I deal with rolling with resistance? So I recognize the writing reflex. What MI is going to invite me to do is to recognize the writing reflex. But instead of responding, I'm going to try to understand what my client is saying by listening reflectively so that they're empowered to make the decisions that are right for them. Okay, so rather than feeling I've got to give the right answer, I'm going to explore what's behind there. And it might actually set the stage for, there might be a point here where I want to bring some information in, but having heard the client's perspective on it, so you see it this way, and you're pretty convinced that that's what's right for you. Would you be interested in hearing some other ways that people have solved this problem or whatever? Then, yeah, they might say no. Well, okay, great. We don't need to waste time. But usually the client's going to go for the bait, right? And at that point, to say, well, what would that be? Well, here's what I've learned through my experience of working with people who are anxious, and going into a novel situation, or the literature says, or whatever. And so your opportunity's there. But if you prematurely go to but, and you cancel out the yes, then the client's not going to feel understood or listened to. You're going to feel right, by the way, that back to that, right? But you're not being effective in MI terms. And so this is, again, back to one of the themes of the day. How can we use all the good stuff we know to be really effective therapists? And the evidence is the more that we can engage empathically with people, the more that we can help them kind of make the changes that are going to matter to them.
That are going to matter to them. That's key.
Thank you so much, Wayne. And that was a great kind of tip as we're sort of wrapping up. Sorry, Beatrice, if you have any announcements you want to make as we're I know we're going a little bit over time.
There's a question in the chat, Camille, that you may need to respond to that has to do, it's a question actually, it has to do with certificates.
Oh, yes. So yeah, I know that as we're wrapping up and folks are leaving, I also wanted to let everybody know that I'll be following up after the session with an email that will have the links to everything that was discussed, as well as a link to request a psychotherapy certificate of attendance. And I was also wondering, Beatrice and Wayne, for those who are able to stay on for a couple more minutes, if you had anything you wanted to say about, there's a mental health and addictions course that Adler is running that has both Wayne and Beatrice, and they're going to be talking more about motivational interviewing, specifically mental health and addictions. And I'll be sending out the link to register for that if you're interested in learning more in that post-session email. And Beatrice and Wayne, if you have anything to add.
We are starting on September the 24th, and we've taught this course, I think, very successfully a couple of times. Some of you in the audience, I believe, have been students of ours. And the focus is not necessarily on the diagnostic pieces, although also, but much more in everything that we spoke about today, is how to be effective when working with clients whose circumstances are complex and addressing the complexity from a broad perspective. Maybe Wayne, you want to add a little more?
No, well, that's well said, Beatrice. So yeah, we try to make it case-based, and so there's sort of a practice session where we try to work on actually, what is it like to use some of these skills with clients, to try it out, for people who are learning. So yeah, no, it's fun that way actually, and so we're trying to move towards this kind of learning actually, which is always difficult in a course situation because of limitations. but that doesn't mean that the opportunity to do a bit of that isn't there. And so it's been actually very satisfying to work with Beatrice and David to.
Right. We have our colleague David Brown, who lives in Winnipeg. So through the wonders of Zoom, we can now include his expertise, and he's wonderful and really excellent at this work. We're also developing a new course that I'll be teaching with David Teplin in the form of micro-credentials for those of you who are interested. And it has to do with clinical interviewing. So stay tuned. We're just developing the 4 sessions that are going to come up in the fall. They're on GAD and social anxiety, major depressive disorder, and persistent depressive disorder, borderline personality disorder, and cannabis use disorder. So all things that are highly useful and perhaps of interest to some of you. Anyway, this has been amazing. Time flies. Thank you, everybody.
Thank you so much, Beatrice and Wayne. This was really incredible. And thank you everyone who was able to join us on Zoom. I hope you learned as much as I did. I really appreciated you having you both here, Beatrice and Wayne. Hopefully we can have you back again. And hopefully those who joined us today will be able to join us for our next webinar. It's on Thursday, June 10th at 12 p.m. with Dr. Kanisha Siblis on anti-Black racism and the law. I hope you're able to join us in 2 weeks. And thank you again, Beatrice and Wayne. And I hope everybody has a great rest of your day.
Thank you.
Thanks, everyone. Thanks for your questions.
Thank you.
Bye now.